Are we ready?
Yes, sir.
Okay, so it's great to welcome everybody to the July
Please turn on your microphone.
Oh, okay.
Or talk to it, yes.
Yeah,
Great.
I need to talk into it. Okay, so welcome everybody for the Joint Conference Committee for Zuckerberg San Francisco General Hospital on July 25th. We'll ask Mr. Morris to please call the roll.
Yes, sir. I'll start with you, Commissioner Chow.
Yes.
Commissioner Christian
Present.
and Commissioner Green.
Present.
I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We go on to the second item.
Yes, please.
Sure. It's the approval of the June 27, 2023 ZSFG JCC minutes, and I want to again thank Angelica for filling in. You did a fantastic job.
Yes, you did. And do we have a motion to accept the minutes of June 27th?
So moved. Second.
And there is someone on the public comment line, so I'll just want to make sure that we ask at each item.
Yes.
First on the line, if you'd like to make comment on this item, which is item 2, the minutes, please press star 3. I do not see a hand.
Thank you. Seeing no corrections being offered, we'll proceed with the vote. All those in favor, please say aye.
Aye.
Aye. All those opposed, the minutes are approved, and we'll move on to the next item, please.
That's great. Item 3, the regulatory affairs report.
Good afternoon, Commissioners. Adrian Smith, Chief Quality Officer, here for Emma Moore, who is on a well-deserved vacation today. I'd like to present the regulatory affairs report. We still have several outstanding surveys. We're eagerly awaiting the state and the Joint Commission to come and undertake our triennial surveys. We have completed several surveys in the last few weeks, most notably our 4A SNF annual CMS recertification survey and the Fire Life Safety Survey that follows that. We've submitted plans of correction for both of these surveys, and we're waiting to see if they've been accepted. We also had some surveyors on site to review 2 facility reported incidents and 1 complaint. Verbally, we were advised that there was no deficiencies to be cited, but we're awaiting supervisor review. And in June, the Department of Healthcare Services began the annual survey of the Mental Health Rehabilitation Center and the Behavioral Health Center. It was only half of the team that came, so this was not complete. They actually arrived yesterday afternoon to complete that survey, and we're anticipating that they exit today, so there'll be more information to follow on that. And we'll follow up with our plans of correction from those surveys once we have identified that they have been accepted. As you can see, we've had several facility-reported incidents, 2 COVID outbreaks, 1 in 4A and 1 in the med-surg area. To follow up on the question about the 1 in the med-surg area, there were 2 affected patients and 3 affected staff. And it was 2 patients that were in one of our shared rooms with a CNA, and the CNA was one of the 3 affected staff. So we from investigation, we believe that we're not sure of the original source of the virus, but it was certainly the close contact in that room that began it. But only 2 other staff tested positive during serial testing. Serial testing lasts for around 5 to 7 days, depending upon the epi-linkage, and there were no other cases that showed up on that. We can see that HAPI and privacy breaches continue to be our biggest risk as an organization from our the data that we've collected up to this point this year. Moving on to the data that we're presenting regarding monitoring from our plans of correction. The first piece around the HAPI plan of correction, The data that we're monitoring isn't directly related to HAPIs. One of the findings in the survey was that one of our policies was past due its review every 3 years. So it's all of the policies, all of the administrative policies that are due each month that we're auditing to see if any more are past their due date, and we have reached the threshold of compliance with that. The second is from our Joint Commission Stroke Survey, and it was all around the clinical care that patients were receiving. NIR stands for Neuro Investigational Radiology. So they're the order sets generated after someone goes to the IR suite when they come in with a closed head injury or stroke. And we have continued to audit, especially our compliance with our patients who are MPO, and we keep our stroke patients MPO until they have either had a successful swallow study or they've been assessed by a speech pathologist or speech therapist. So our patients in the initial stage are MPO, and their meds are delivered by nasogastric tube or other methods. I think that brings us to the end of our monitoring data. Do the commissioners have any questions about the regulatory affairs report?
And there's no longer anyone on the public comment line, so no public comment.
Okay, commissioners, questions on the regulatory report? My question that remains now, which I circled here, was under your medications ordered as given orally when a patient is NPO, you had on the slide that in June, for example, you had an N of 1, but it looks like there are 5. I mean, so is that 5 instances, or I mean, what? And then back in March, you have an N of 7, and then you have 70. So I'm not sure what all the numbers meant on the graph.
So the N is really low because it's a snapshot of the inpatients on the day of audit that meet the criteria to be compared against our corrective action. And in those days, there was a very low number of patients that were MPO at the time of audit to see if we were compliant with the documentation of our medications.
And so what does, for example, in March, what does 70 indicate out of the 7 patients that there were?
Oh, okay. I'm sorry.
Yeah.
So they're individual medications. So it wouldn't necessarily be 70 patients. It would be 70 medications.
I see. Okay.
And
All
I think one of the things that was demonstrated to us at survey isn't that nurses were giving medication to the patient by the wrong route, but because orders didn't reflect the actual status of the patient, we were charting against how the order was written as opposed to the actual status of the patient. So oftentimes the patient was no longer MPO, but the order had been written that way and not changed when the patient's swallow status had been changed. So it was multifactorial as to why we saw that deficiency. Some of it was around the length of time we keep our patients MPO, but the majority of it was around the orders not catching up with the status of the patient.
Okay. So you're happy with this?
Yeah. No,
curve at this
it's
point?
moving in the right direction, and we're demonstrating that our change is working.
Okay. Any other questions? Yes, Commissioner Christian.
Thank you. Is there anything you can tell us about the sexual assault that was reported?
Yeah, so I can. I brought the information with me, so we talk about that. So there was 2 patients in our inpatient psychiatry, and there was, this is one of the incidents where we use a definition from the Joint Commission, which is, it describes any touching of specific parts of the body by another patient, and we have to then differentiate that as a sexual assault. So if if one patient puts his hand on the buttocks of another or on the chest area that could constitute the breast of another, we consider that and we investigate, and we really begin to figure out whether there was any intent on the part of the patient, and if there was, and we also look at consent of the person who's being touched, and we look at the big picture. And oftentimes the patients in psychiatry have altered inhibitions and can come in vulnerable, personally vulnerable, and also vulnerable to do the wrong thing and act in a way that they wouldn't normally act if they weren't psychiatrically disturbed. So in this case, the victim was treated and checked out, and there was no further treatment needed. And the alleged perpetrator, within 24 hours, the incidence of their psychosis had reduced significantly, so they didn't need to be monitored one-on-one. But we take these incidents very seriously, especially in psychiatry. And compared to other organizations, I believe that we have a much lower threshold for considering something a sexual assault.
Thank you. And so you determined that it was part of the experience of psychosis that this person was undergoing?
That's correct, yeah.
Thank you.
Any further questions? If not, then let us go on to our next item, please.
Sure. Thank you, Mr. Smith. Item 4 is the True North presentation, True North Ensuring Access and Flow. And I will share my screen to give that presentation. Give me 1 second. Yes, I can share. Give me 1 second to pull it up.
Good afternoon, Commissioners. Can you hear me okay?
Yes.
Luke Day, Chief Medical Officer. While the slides are loading, I'm happy to share with you an update on our strategic A3, access and flow. Executive sponsors for it include myself and Jillian Otway, who is also on a well-deserved vacation right now. What I am planning to do today is really 3 objectives. The first is share some data with you on where we have come over the last couple of months, really trying to paint a picture of where we are as it relates to access and flow. And I'm specifically going to focus on the inpatient unit, so inside the hospital. Second, try to draw some conclusions and insight from that data, because I think that's going to help us inform what our countermeasures and interventions are going to be and what some trends are. And then finally, share with you some interventions that we have been working on over the last 6 months to really try to improve flow on our campus for our patients. So we're really excited to share this with you. Next slide, please. So to start us off, one of the questions we had at the beginning was, is the hospital much fuller than it normally is? And to answer that question, we have to look at occupancy of beds within the hospital itself. And we heard from our staff, and we've heard, quite active concerns raised over the last several months that the hospital is fuller than it has ever been. And so we really wanted to look at this and really sort of get a better understanding of it. So this slide here looks at med-surg bed occupancy as a percentage. It looks at it over the last 3 years. Our goal is always to be, below 100% being full. You can see that we've never really achieved that target at ZSFG. But when you look over at calendar year 21, and probably for the years before that, on average, our bed occupancy was probably at about 105 to about 110% full. So still above what we'd like it to be, but that was sort of our average. Fast forward 2 years, you can see that number has skyrocketed. It actually has gone up probably by about 60%, to where now, on average, our hospital is at about 125 to 130% full on a daily basis. So a significant jump in our bed occupancy. So that begs the question of what's causing this? What are sort of the root causes of this? And so really trying to use some of our lean tools, we dove into this data a little bit more. Next slide, please. So one of the questions you may be asking is, we've done a lot of work on ambulance diversion. We had some recommendations and guidelines from the state that we had to improve our ambulance diversion beginning in November of last year, really trying to reduce it from about the 68% that it was down below 50% with a goal of 30%. As you can see here, we did some tremendous work at improving our ambulance diversion. So the blue arrow right there highlights when we started our PDSA to improve ambulance diversion. You can see we had remarkable results with it, going down from an average of about 60%, going down now to about 40%. So remarkable results there. What you can see, and I think this is one of the questions that was asked, was did we see a concomitant rise in the number of admissions to the hospital as a result of improving ambulance access to the hospital? We did. But that's not the entire story. So when you look at the data a little bit more, we did see an increase in admissions to the hospital with a reduction in ambulance diversion. That increase was about 4 per day. But when you look more closely at those 4, it's only about 2 med-surg patients that constitute that number. One is ICU, and then the other one usually goes to another service. So it's about 2 extra med-surg patients a day that were admitted to the hospital with improving ambulance diversion. Next slide. So I apologize for the size of this, but we're a very data-driven organization, so we wanted to apply some really rigorous statistical modeling to really, again, answer that question. The question being, is there a relationship between our med-surg bed occupancy and ambulance diversion, or our daily emergency room admissions? So on this slide here, thank you, really what we're trying to do is sort of understand the relationship between the two. Does the daily ED admits explain hospital bed occupancy? The R squared there really tells you what that relationship is. The closer it is to 1 means there's a really strong relationship. The closer it is to 0 means there's really not much of a relationship. What you can see here is it's pretty much close to 0. It's 0.15. So while we're seeing a slight increase in the number of admissions to the hospital, this does not really explain our overall increase in bed occupancy. So I think this is really sort of, forced us to think about, well, what are other things potentially that are causing that higher bed occupancy that we've been noticing? Next slide. And then this slide here really, again, just sort of emphasizes and I think reinforces the last slide, is that, again, when we look over the last several years, and this is really looking at the winter months, so looking at the beginning of winter back in 2022, comparing it to 2021, there really hasn't been a significant change in the number of med-surg admissions to the hospital. It's really gone up by about 1.5. Next slide. But I'm sure all of you are asking, and probably the big room in the question is this, well, what about the decertification of Laguna Honda? What has that had in terms of an impact on ZSFG and our bed occupancy? And I think this slide here starts to tell that story. So this slide looks at the last 3 years. In the center, you can see when Laguna Honda stopped admitting patients, when the decertification really took effect. And this stop admitting patients was no new patients could go to Laguna Honda. So many of our patients who have complex social situations, it's an acute skilled nursing facility, we didn't have that option to send our patients to. That began in and around February of 2021. Now, prior to that time, if you look at our lower level of care patients, that number was at 25. And it had been 25 for a pretty significant period of time. And that number really, I think, helped keep our census at a manageable level and helped us to be able to move patients through the system itself. When you go to the other side, you can see that number skyrockets. It actually goes up almost by 12 patients. So it goes up close to 39 lower level of care patients on a daily average are at ZSFG since Laguna Honda got decertified. Next slide, please. So going back to our statistical modeling, we then wanted to ask the question again, well, what's the relationship between bed occupancy or med-surg occupancy and lower level of care patients, or our daily lower level of care? Unlike that first slide I showed you where it was 0.15, so close to 0, this one is 0.7, so it's much closer to that 1. So this tells us that the decertification of Laguna Honda, one factor, I think with a host of other factors in the city of other bed closures, has contributed to a rise in our number of lower level of care patients in the hospital, and that is one of the factors that has been driving a higher bed occupancy. Next slide. The other thing we also wanted to look at was length of stay of our patients. So we know that that can also impact bed occupancy if patients are staying longer on our hospital services. There's a multitude of reasons why that might be occurring, but we wanted to ask that question to better understand if that was one of the drivers. And I think this slide is very telling in terms of that story. So back in 2019, on average, our average length of stay was about 6.6 for all of our med-surg patients, so 6.6 days. If you look at 2023, that number is 9. Now, we're only halfway through 2023, but when I ran the numbers again today, it's still pretty close to 9. So we've almost gone up by about 3 extra days in terms of our length of stay over the last 5 years. And when we break this number down by service, our top 4 largest services, so medicine, family medicine, general surgery, and cardiology, almost every service has had a length of stay increase by 1 day. Now that may not seem like a lot, but it has a significant impact. And so when we run the numbers, if we could reduce our length of stay just by 1 day, it would free up about 22 to 23 extra beds per day for the hospital, which would allow significant move through the system and potentially reduce that med-surg occupancy percentage. Next slide, please. So we wanted to dive down into our lower level of care patients a little bit more to really try to understand, well, what are factors that we potentially have control over or things that we can intervene upon. This is a really nice slide from our Department of Care Coordination. It teases out all of our lower level of care patients by the number of days that they're in the hospital. Now, I think in general, when we've talked about lower level of care patients, we think of these patients as patients that are in the hospital for 30, 60, 90, maybe even over a year. But actually, the vast majority of our lower level of care patients are there only for about 1 week to 2 weeks, which is interesting. So it's a sort of what we call short stay lower level of care patients. And so this basically raised the question of, well, what are things that we could do to identify this group of patients? What are some of the barriers and challenges these patients and their families are facing? And what can we do as a system to help support them? Because this appears to be one of the biggest drivers. Next slide, please. Sorry, Mark.
Yeah, it's okay.
So moving on to the third objective, taking all this data into account. So increased med-surg bed occupancy, much higher and unprecedented levels that we're seeing, not really driven by higher admits from the emergency department and as a result of improving ambulance diversion, but really driven by our number of lower level of care patients and our length of stay increasing over the last several years. Now we know this is a multifactorial problem, and so we wanted to approach it from the same vantage point. This slide here, again, is very busy, but I think really encapsulates our Department of Care Coordination's work in terms of how they're trying to address this issue. This slide here looks at both internal and external countermeasures that they've been working on to help with our lower level of care patients. So some highlights from this: we have a dedicated lower level of care team that consists of a physician, social worker, and utilization management nurse that on a daily basis run our lower level care list, reach out to the teams, try to help develop disposition plans for them and remove barriers. We also have active engagement of our social medicine team. We also now are working with our ED staff to identify patients who are in the emergency department who might be possible to be discharged from there. So rather than moving them upstairs, if they're going to be discharged in a few hours, try to expedite that. And then also we're trying to identify patients earlier who might have barriers to discharge. So if there's diagnostic tests, procedures, or surgeries that potentially are the linchpin to them getting home, we actually will try to expedite those specific cases and advance them so patients could go home on an earlier basis. Next slide, please. Then we also wanted to bring all of our teams together to address this problem. So beginning in December, we convened together our flow committee, which is all of our operational leaders in the emergency department, med-surg, critical care, and the Department of Care Coordination. We first started meeting on a weekly basis. We now meet on an every other week basis. And really the goal of this meeting is just like today: share data, develop some countermeasures, or have countermeasures presented to the group that could improve flow, but I think also bringing people together to sort of interface and communicate with one another about the challenges that we're facing. This slide here just really highlights some of the work that is being done. So we now also, in addition to having our Department of Care Coordination lower level of care team, we have individuals who work on lower level of care patients directly in the emergency department, so trying to prevent admissions or trying to find other alternatives in the community, and then also a lower level of care team on med-surg as well, focusing on that particular group of patients. Much of this work is really around reaching out to our teams, communicating with one another, and trying to standardize a lot of our work. Next slide. And then lastly, in the last 6 months, we've also implemented several interventions to help support our teams. So in particular, we've been able to use some funding to expand some of our busiest clinical services. So winter is usually the busiest month for us. So we've expanded one of our hospital service teams to carry more patients. We also provided funding to our family medicine service to care for lower level of care patients specifically. And then we also were able to add an extra ICU or critical care team during the winter months, which helps significantly offload these services. Also, thanks to the outstanding work of our nursing colleagues, in particular Jillian Otway, who is very innovative in terms of how to deploy nursing resources to help staff one of our additional units on the med-surg floor, H58, but also using med-surg nurses in the ED, knowing that many of our patients boarded down there quite a period of time. By having the med-surg nurses there, the goal was that this would hopefully improve communication between our teams that are upstairs and med-surg nurses downstairs, and would help facilitate better communication, care, and potentially even earlier discharges. And it also helped offload the ED. We also launched a medicine training moonlighting service. So we now, when our census reaches a critical level, we can activate trainees to come in between the hours of 6 to 10 p.m. Because of duty hours, to help with admissions. So they can admit at least 4 patients per shift. We've activated this on several occasions, and it's been quite effective. We reviewed some of our medicine census sharing guidelines, so really trying to make sure that patients really are appropriate for the service that they're on and make sure that there's level loading. We've also begun to revisit our ED admission and consultation guidelines, so really trying to determine how we triage patients, determine what's the best service for our patients, but also if there's issues in terms of where patients need to go, how do we de-escalate that and have a thoughtful pathway forward. And then finally, with our ED or with our ambulance diversion improving so much, this has had benefits for our patients, but it also has had some downstream effects as well. It's impacted our waiting room. So we've seen longer waits within the waiting room and higher left without being seen. And so we now are using our Kaizen promotion office and launching a Kaizen over the next several months to really focus on the waiting room itself, to try to develop more robust and thoughtful interventions there to help our patients who are waiting. Next slide, I believe. Yes, that is it. And with the question that you asked, so thank you very much. So the questions on the graph, talking about the relationship between the diversion rate and the med-surg occupancy. So yes, we did see, it's almost, you can see they're almost sort of like diametrically opposed to one another. As one went down, the other went up. It didn't go up as much as we thought it would. We expected many more admissions to actually be coming through the emergency department with the improved ambulance diversion, but it really is only about 1 to 2 med-surg admissions per day and probably about 1 ICU admission per day. How did COVID affect admissions? In general, I think at the height of the pandemic, the ED's census was probably at its lowest that it had been in several years. Since COVID has been waning, we've not seen a significant number of COVID admissions coming through the emergency department. It's mostly asymptomatic patients done through our routine testing. In the past, patients would come through ambulance, but I think most of our patients who have positive COVID tests are actually asymptomatic and coming through the triage area. Firefighting challenge. Yes, it's a catch-all term. Really, I think what they were trying to highlight on that intervention slide was our Department of Care Coordination is a quite busy service, and so there are many challenges they face on a daily basis trying to help discharge patients from one service, helping to support patients in the ED, making phone calls to our community outreach services. So I think that's a lot of the firefighting. There's also some times where there's understaffing, and so they're trying to cover services that they're not so familiar with. So I think that was the firefighting they were alluding to. Examples of lower level of care at admission. So this is a problem we've known about in our system. I would say in general, these patients fall into the category of needing placement. So where their primary care doctor or community-based outreach programs have really been working with this particular group of patients and have not been able to place them or no longer can care for them safely at home. And so they'll bring them to the emergency department essentially as a last resort. That is by far the highest number that we see that fall into this lower level of care. There's no one admitting diagnosis that predominates here. There's a whole host of diseases that potentially also accompany this, but it's mostly patients who just are no longer able to care for themselves at home. And then ELT, that is the executive leadership team. So it's our team that meets together with stakeholders from ZSFG and from the network and Laguna Honda that come together to discuss EPIC. So any significant changes, operational issues, implementation, all of those decisions get funneled to the ELT where it's made decisions are made on a monthly basis. And with that, I'm happy to take any questions or feedback or comments. I know that was a lot.
And commissioners, there are a few people on the public comment line, so I will ask folks on the line if you'd like to make comment on item 4. the True North Ensuring Access and Flow presentation, please press star 3 now. All right, no hands, commissioners.
Thank you. Commissioners, Commissioner Christian.
Thank you. So, not being a physician, I'm sorry in advance for this question, but revisiting current ED admission and consultation guidelines. The ED admission is kind of self-explanatory, but I wondered if you could expand a little bit on consultation guidelines. Is that with the people that come in or amongst the physicians?
That is a great question. You would think ED admissions would be straightforward, but in practice it's not. I think, what we have been experiencing, and it's not just our hospital, but it's really who the ED physician has the authority to decide who needs to be admitted to the hospital, but determining which team they go to sometimes can be a challenge. So there are sometimes overlapping diseases, whether it's medicine or surgery, and sometimes there's disagreements about which service it can go to. So the goal of this committee is to try to really focus on who has the authority to make that initial decision, and then if there are discrepancies, those discrepancies would be handled once the patient is admitted to the hospital. What happens in the ED now is consults are called, people will write in the chart, don't admit to my service, admit to another service. We're trying to sort of move away from that culture of more, how do we be collaborative together? How do we work together? Make a decision that the patient has to be admitted, try to do our best to admit them to the right service, and then if there are any concerns, then we will work those out at a later date. The same is true for the consults. It's really trying to establish clear guidelines of if a patient comes in and a consult is needed, that we will respond to those consult requests, do so in a timely manner, and try to give a time frame that those consult requests will be adhered to. And then again, if there are any questions about admission, that there is a point person who would make that final decision to help the patient meet their needs at that time.
So yeah, it does, bring to my mind the experience of the patient who comes in to this environment, and what I'm hearing you say is that the staff is focused on that as well.
Correct. Yes. The goal is to serve the patient, to provide the best service to the patient, and to provide them with the right team and care based on the condition that they're presenting with. And also to try to get away from a culture of, and at least this is the perception among some of our services, of I can say no or you need to do this. It's really to try to get away from that. It's more how do we work together to decide what's best for the patient and support our teams as well.
Thank you.
Commissioner.
This was really great, thank you. I wonder if you can elaborate a little more on how COVID might have affected all of this, because obviously the ICU admissions were way up, and yet those may have been people who were easier to place because they had that diagnosis. But then I recall at the beginning of the pandemic, trauma went down, or at least, the number of incidences of accidents and police actions and so forth also dropped. So when you look at this, especially because these are all data derived during the pandemic, is there anything you would anticipate going forward, like the trauma admissions would go up? And ultimately, how do you think Laguna's reopening, especially because there may be some slight changes in who can be admitted there, how do you think that'll affect this going forward?
Yeah, no, that's a fantastic question, and it's one that we should probably put little asterisks on the data, is that a lot of it is taken from the time of COVID, where both trauma and med-surg admissions were down. And then sometimes during our winter months, when we had our COVID surges here, the city was completely shut down, and so it was really only people who had COVID that were in the hospital, so the numbers were, I think, a little bit lower. When we have looked farther back, a couple of things that have been to note is, one is our length of stay still has gone up, even pre-COVID. So that 2019 number right there, when it was about 6.6, was all pre-COVID. And the fact that we're now at 9, I think tells the story that there is something that's leading to slowing down of basically patients being able to go home. With Laguna Honda closing, even when we go in prior years before that, the lower level of care numbers were probably even a little bit lower, probably at about 2021. So they had gone up a little bit prior to COVID, but they were in those low 20s. And so the fact that we've seen a high spike as well with the decertification, I think speaks to that as well. In terms of Laguna Honda opening, we are cautiously optimistic and hopeful that it will. We do realize that it will probably not be to the same extent that it was before, that there'll probably be more restrictions and regulations that will be in place about the types of patients that we can send over there. But we are hopeful because a lot of our lower level of care patients are skilled nursing facilities patients that really only Laguna Honda would be their only option. And so our hope is that they will probably decompress us 1 to 2 patients a week. We are just really, I think, as the rest of the city, suffering from just a lack of beds, both in terms of behavioral health and psychiatric, but just other beds for our patients who have many comorbidities. But there's just not a lot of options right now, especially post-COVID. During the time of COVID, there was the INQ hotels, there were more respite beds, there were more shelter beds. Those just aren't available anymore, and unfortunately, we don't foresee those opening up in the future.
So in terms of all the behavioral health beds and all these initiatives that the mayor is putting in place, it may not have an effect on the lower level of care that we might have hoped?
We are hoping, our concern potentially is that it would probably be a few years before we might see some of those results. So I think our hope is that Laguna Honda opens up. We still have a really strong partnership with Chinese Hospital, which I think helps our patients. And then I think also really working with our Department of Care coordination team, who is incredibly creative and knows all of the resources in the city to, again, try to support patients and their families at home and trying to sort of having to avoid to have them go to the hospital unless it's absolutely necessary.
Great, thank you.
So this was really a very nice presentation on where you are. And so the 9 days average length of stay, is that for people who actually are under the acute care and not counting the length of the...
It includes all comers.
It includes all comers, including
comers,
the
yes.
decertified and all.
Correct.
So have we looked at, just to see if we're managing the acute care well, whatever the acute care average length of stay is, has that gone up?
So I don't have that specific data. What I can tell you, and I can come back to the commission and provide more robust data on that. We know that probably about 1/3 of our hospitalized patients stay there for only about 3 days. However, what we have been seeing is the length of stay, or at least the time that the patients are there, is actually creeping up a little bit more. We think this has to do with several things. One is some operational inefficiencies, but also just the teams are incredibly busy. And so while they're admitting patients, they have to discharge patients. And so this creates this churn that causes some delays. And so we are seeing some excess time of patients staying in the hospital as a result of that.
Okay, yeah, because I think if we're looking at efficiencies for the patients who were acute, I mean, obviously the lower length of stay is a very huge issue, and about 1/3 of the hospital seems to be either lower length or decertified. So, if we were able to move all those people into the right places, we could stay within your guidelines in terms of below 100%, right?
If we could, I guess one of the things that we are, and this is the thing we're trying to focus on right now, is we're trying to reduce our length of stay by 1 day. That's probably going to be one of our new goals over the next year and a half. What we're going to try to focus on is the acute patients as well. So really looking at what are barriers there to getting them out earlier, whether it's discharge medications, procedures, diagnostic tests, and then also looking at that lower level of care group that stays only about 1 to 2 weeks. Because when we looked at that, about 1/3 of those patients actually go home, and then 1/3 go to a skilled nursing facility. So we think there's some opportunity there to try to shorten those stays as well.
Great. So I think in the next report, it would be nice to break down what that 9 was, because then we could also be watching how well we're handling the acute care, and is this also related to increasing severity of illness versus not, right? Because that's another issue that this by itself, because it's focusing on the lower level of care as...
A great question about the severity of illness. So and I didn't share that data, but we looked back the last 7 years of our highest volume services, so surgery, medicine, family medicine, and cardiology. We looked at the acuity of their patients. There is no difference over the last 5 years. So
Okay.
there's zero difference in the acuity. It's exactly
Right,
when you
good.
look at diagnosis codes, billing codes, CMI, everything that we can basically have that tells us how sick or severe a patient's illness is, they're all exactly the same over the last 5 years.
This is a small question that's off of your, interventions that are occurring, and that has to do with using the medicine trainee moonlighting shifts, and whether this interferes also with the guidelines from the graduate education boards or whoever it is that controls how much time you can have in the hospital. Does that count, or?
It does count. So we're very cognizant of that. So that's why it's only for 4 hours. You note they can only be on an outpatient rotation. I think you notice it starts at 6 p.m. So they'll finish clinic at 5, hopefully, come over to the general, and then by 10 p.m. they have to be out of the hospital and done with work. That gives them enough time to go home and get their over 8 hours of sleep. And those extra 4 hours that they may work shouldn't really count too much to their 80-hour work week. Also, the residents, I've heard, really enjoy it because the general is a place they like to go to, and it's some extra funding that they're provided.
Okay. Yes, Commissioner.
Commissioner Chow made me think of something, which is we have a big problem with length of stay on weekends because people don't really know the patients and they're reluctant to send someone out. Plus, it's extra work. So do you have any data at all about how Saturday, Sunday affects the length of stay and what you might do to try to kind of address that? Because it is a challenge when you don't know the patients and you're insecure about it, especially complex patients, sending them out.
No, I have not broken it down by weekday versus weekend, but I can tell you that there is a significant difference in the number of discharges during the week compared to the weekend, almost by a factor of 2. You can see it drops off from Saturday to Sunday, where sometimes we only have 10 or 11 discharges on the weekend, as opposed to sometimes we have 40 during the week. Multifactorial problem as well. Some of the challenges we've experienced there is many places are closed over the weekend, so many of our support systems within the city and many skilled nursing facilities or just receiving facilities don't accept patients over the weekend. So we've been trying to partner with some institutions on changing that. And then also some of the testing that is needed, so endoscopy, echocardiograms, some radiographic studies, those slow down just because there's less staff over the weekend. We're doing a Pareto chart right now, so really trying to drill down in what are those key things that might be delaying some of the discharges over the weekend that we have control over within the hospital. We've really been focusing on patients don't want to stay an extra day or 2 in the hospital over the weekend if they don't have to, so we should really try to focus on prioritizing those specific procedures or diagnostic tests so patients can go home.
Thank you. It'd be really interesting to get more granular information as you delve deeper into this, because I think it's a pretty, an industry-wide issue about, and a lot of it's just insecurity or not knowing patients. I'd be curious to know what you come up with.
We see it, I see it almost on a weekly basis, and you can actually see if there are more discharges on a Sunday, it actually sets a different tone for the week for all the teams, so it's much more level loaded. So we definitely know that it has benefits. And so we're just, I think, scratching the surface on trying to improve that.
Great, thank you.
So I think this is a very good report to get us all excited about what your outcomes are going to be. And I note that you've listed that your outcome metric is a 10% reduction by September. When do you think that a follow-up report here now showing, the progress that's going to be made through your many interventions here would be appropriate?
I would say, if the commissioners are okay with this, November, December. I think by that time we'll have a more complete picture of the numbers for the rest of 2023 in terms of length of stay and bed occupancy. But I think it'll give us almost a full year of many of the interventions we outlined here to see how well they're actually driving improvement.
All right, so I think we'll put that on the calendar. And again, it's great work in terms of showing how you're analyzing the problem, seeing it, trying to make the interventions, and now we'll, hope that the goals that you have established are going to be achievable. So thank you very much.
Thank you all again, and thank you for the questions.
All right, thank you. We'll move on to item 5, the Chief Executive Officer's Report and Emergency Department Newsletter.
Good afternoon, Commissioners. My name is Andrea Turner, and I'm the Chief Operating Officer, and I'm filling in today for my boss, the CEO, Dr. Ehrlich. So I will be the one to present the Chief Executive Report. as you know, she's on a much-deserved vacation. I almost feel like everybody decided to do their vacation right around a good time, which is now. So that's great. I wanted just to highlight some of the things that we are so excited about that are happening right now on our campus. So the first one is the capital projects, and I'm really happy to say that we're really grateful for the 70-ton chillers to be installed in Building 5. It's actually setting the groundwork for the infrastructure for the IT network equipment as they're getting ready to build in their IT structure. So this was something that we needed to get done before they could do that. Pride Hall relocation, if you haven't been to our campus lately, please come over and get a tour of the Pride Hall building. It's really beautiful. They are now relocating into, they being the UCSF, are moving into the building. And I'm happy to say that ZSFG and UCSF are collaborating very well in that move to minimize the disruption to the operations of our hospital. Care experience. This is also a very wonderful time for us to share that we have the new electronic consents that started in June, and these are it started with the surgical procedures where patients are able to sign their consent and to ask questions and things of that nature. So this is really good. We give them iPads, so they're able to do that. And then to celebrate equity and Pride Month, last month our theme was looking back and moving forward. This theme was to remind us of how far we've come and how much farther we have to go. Developing our people, we have, I will say a couple of things here. We have the 4A survey that we did really well on with only a few deficiencies, and then the trauma survey, which we had 0 deficiencies. So that went very well. And I'm also happy to say we have 2 new execs that joined our team. Dr. Hemel Kanzaria, who has joined as our Chief of Performance Excellence, and he's also an associate professor in emergency medicine and was the former medical director of care coordination, so happy to have him. And of course, we have Dr. Gabe Ortiz, who is now the Chief of Staff, and he will be presenting shortly, but some of his credentials are he was the medical director of MedSurg and also is pretty engaged in our lean efforts and working to make our vulnerable, at least to take care of our vulnerable population in an equitable way. So happy to have them. I also wanted to take this time to answer the question about workplace violence that you had, Commissioner Green, about data. And I presented a couple months ago about that, and I wanted just to share. So again, we started with a new reporting system, which is SAFE, and we went from the UO system. And I believe, Commissioner Chow, you wanted to know more about how we're gathering our data as well. And so that is ongoing. We do have data that I can share. And what I want to learn from you all today is how often you'd like for me to come and share the data with you. But we do have substantial data around it as far as how many workplace violence assaults that we're seeing, both verbally and physically or physical. And we also have it broken down into departments as well as gender. What we don't have, and we're currently working on that, is the gender of the victim or the person that was assaulted. So we're working on that to find out pretty much who are really getting assaulted. Today we had another really good meeting where we talked about the form that we are looking to deploy to our staff as to, when they do get assaulted, to fill it out so we can learn more about that. But I do have the data that I can share with you at maybe the next meeting or however often you'd like for me to come and share that data. And I really want to appreciate Susan Brockovich, who is no longer with the organization, because it was her brainchild. She listened to the things that we were asking for, and prior to her leaving, her and her team worked to ensure that we would have that data available to us. So yeah, I would definitely like to learn from you guys how often you'd like to hear from us. Okay, what questions do you all have for me?
Are there public comment?
I will check. Folks on the line, we are on item 5, the CEO report and emergency department newsletter. Please press *3 if you'd like to make public comment. No hands, commissioners.
Okay. Good. Commissioners' comments. Yes. Commissioner
Yes.
Green.
I think it would be really helpful to get more frequent reports. Probably Commissioner Chow has the best advice, partly because it puts some of those fries in context. In other words, when you see one report on a month, but you don't know what else has gone on in the background. I know it's been such an effort among all of you, especially Mr. Price, working across the system and putting it in the context of the system and things that we're trying to do both at Laguna and the General. I think it'd be really helpful to know, and it's certainly one of the big, I think, issues that has come up among the staff in the ED. So just, comment on that. And I'd certainly ask Dr. Chow to decide on frequency.
Well, I think what we should do is see the breakdown and what you're all doing in terms of trying to analyze and moving forward with the information to try to resolve wherever the issue is. After that, then we could determine, well, how often would we be meeting on this, and what type of data then, because it's beyond the data that's just simply the high level that we're now getting that have caused a concern as to what it is that we're going to do, because we've note the variation, but a continued large number of workplace violence marked here, and again, they're in sort of the same areas that we've been watching for
Correct.
quite a while. So any breakdown, any thoughts, and so forth. So I think we should schedule a presentation when they're available, since it looks like you're completing the gender issue, so that you would have a complete picture that you could present.
Correct.
Then at that point, we'll decide, from your whether we can look at outcomes that are coming, or whether we want to follow the progress that you're, presenting to us in terms of whatever your work plans are, to try to make some sort of a change in this. Commissioner
Certainly.
Christian, any thoughts on that?
Oh, I totally support that and would like to have as much information as frequently as possible that's, reasonable and makes sense.
Well, I would love to bring that information to you all. The 5 areas that you'll see consistently, we're focused on those areas, but we're definitely seeing other areas too. But by far, those 5 areas that you're noticing, as far as how many assaults are happening in those areas, we're definitely focused on it.
Okay, good. We'll do that. I was hoping that we could clarify on Dr. Kenzeria that he's actually volunteering at the foundation board. Is that
Correct,
correct?
yes.
Okay, because otherwise I was thinking, we have another hospital board of directors, which would then create a problem for us trying to determine, where that sits in our chain of command.
Volunteer, yes.
No, that's wonderful. And of course, shortly we're going to welcome Dr. Ortiz. So I had only one thought as I was looking at the data in regards again to our acute psych and the lower level of care. And I realized that if we add up the decertified and administrative, right, on on this chart, then we come to 43, and I'm not sure how many acute patients we actually then have, if that's what it is in June, for example. And so I think we need a better way of trying to also then understand, because I think I raised that last time. If it's labeled as acute psychiatry average daily census of 42, okay, in June. Then when we add up 33 and 10, it equals 43, which are all lower level of care. So there's sort of a disconnect between the two. And I think you could actually, solve it by what we're looking at or trying to see is what is the acute census, and then what is the lower level decertified or administrative. So perhaps that could all be actually on one slide.
Right, okay.
So take a look at that, because we can't have 43 decertified and then 42 as a census, right?
Yeah, I agree. Thank you.
Okay, that's that was just to sort of refine how we're able to continue to follow this, okay?
Okay,
And I think that is all that I had also.
all right, very good.
Really appreciate
Thank
you
you.
standing in for Dr. Ehrlich, and you've just report back to her that you did an excellent presentation.
Oh, I certainly will tell her that. Thank
Don't
you.
forget.
I won't.
Okay, thank you very much.
All right, we can move on to item 6, the hiring and vacancy report.
Good afternoon, Commissioners. My name is Emma Perez. I'm the Clinical Hiring Team Supervisor. I'll be reporting out for the ZSFG HR Operations Manager, as that position will soon be vacated, and we'll be looking to fill that again. So as you can see from our report, our total hospital vacancies slightly decreased to 10.86%, down from 10.90 last month. We've hired a total of 32 employees between June 1st and June 30th. We've had 32 separations during that time, of which 22 were retirements. You will see a lot more retirements in June and July, so you'll expect to see more next month. The RN vacancy rate slightly increased to 8.1. It was 7.9 last month. To mitigate those challenges, we've hired some P103s. We continue having hiring managers speed up the selection process by doing application review. We also have some great RN recruiters who work directly with the hiring managers to establish what that recruitment plan looks like, depending on the specific needs of the position. So they'll post in platforms such as LinkedIn, Indeed, ZipRecruiter, and different association sites. They do source virtually as well as in person through outreach at community-based organizations, schools, and they establish other pipelines to help recruit RNs. They attend job fairs, and of course they stay on top of healthcare market trends to engage qualified candidates. We also continue to work with stakeholders to look at the RN hiring process and to look for ways to reduce that timeline. I think the main focus is to think creatively and look at where there's low-hanging fruit to make initial changes, and definitely the direction is to make some of those changes and then pivot if if something's not working, and try to adjust. HR conducts weekly and monthly vacancy meetings with the hospital executive team to review hiring plans. For the emergency care unit, there's 12 experienced vacancies, and there's 2 selections made with start work dates in August. As you know, that's one of our hardest to fill units. The critical care unit has 3 experienced vacancies with 3 selections made with start work dates also in August. For med-surg, there's 14 experienced vacancies and a couple of selections made with start work date in August. OR has one experienced vacancy, and the selection is currently in progress. Some of our training programs, the critical care training program has a cohort that's starting on August, and they're hoping to have at least 10 trainees. Emergency care training is anticipated August, but they'll have staggered work dates with a cohort of up to 10, and that's because they will be hiring an additional 10 positions that will be routed to urgent care, and once they've gotten some experience there, they'll move on to the emergency care department. Our med-surg training program is targeted for August with a cohort of up to 16. Some of the non-RN positions that have been filled are the 2218 physician assistant, 12930 behavioral health clinician, 12586 health worker 2, 2 medical evaluations assistants, and a food service supervisor. I know you had some questions for us, and I wanted to address Dr. Chow's questions first. So you asked about the public service trainees and what that is. So that's a trainee job class that is really meant to be utilized in various ways. It's to help trainees gain specialized skills to enter entry-level jobs. And in this case, the 9910s are being used for interpretive services. So they're helping, provide interpretive services for our hospital. And I understand there's several job classes with comments on them about the status that I sincerely apologize for that we've had a lot of transition in staffing, and so I think several teams were reached out to, and things have moved around, and so people are like, I don't have that anymore, so I really apologize for that, but I do have statuses for those. For the 2586, it is pending exam administration. They've actually administered the exam already, but are waiting to adopt the list. Same thing for, I think the comment was about the 7524 institution utility worker, but it's really the line below that, which is the 2585 health worker 1. It's also pending exam administration. And for any 2320s or P103s, they're currently in selection process. So, positions have been approved, and we're just waiting for selections to be made. There were also some questions regarding the vacancy trends, and I wanted to just get a little bit more clarification from the commissioners about what you'd like to see. I wanted to understand a little bit if you're looking for maybe something like the ZSFG vacancy rate trend graph, but basically just broken out for ED, critical care, and med-surg instead of being overall ZSFG. And if that's the case, that's something we can definitely work on.
Yes, that was my question, and I think that would be helpful, along with us trying to get an understanding of how, when you hire a P103, the totality of staffing. In other words, I think there was another area where there was a high number of med-surg staff leaves, for example. So when we look at these data, it's so hard to know, especially when you hear from staff that they feel they're understaffed, especially the ED. It's so hard to understand the totality. People always say, well, we're filling with registry. But how often is that really the case? How often? And we, I think a few years ago, talked about this in terms of some of the public testimony, and trying to get a better handle of where we are today on some of those concerns compared to when there was really quite a bit of concern and conflict over this maybe 3 or 4 years ago.
Yeah, thank you for that question. So I can tell you from an HR perspective, when an RN is on leave, that position has not been vacated. That person is still sitting on that position, and so it's not a vacancy that can be filled. However, the P103s are there for that purpose to help fill, temporary needs, and we don't know if a leave is short-term or long-term until, there's been a discussion between hiring managers, and we also have a leaves department who handles some of those leave requests. And so that's really an operational need, and I believe that Christina Bloom from our nursing leadership is online to help answer some of those questions about operational needs.
Hi there. Yes, in regards to P103 specifically, ICU, ED, and Med-Surg all have over 30% of our staff as P103. And that's a legacy issue that we had related to the fact that it used to be more efficient to hire P103s. It's definitely our goal to hire all 2320s and have our positions filled. It is safer for the patients, better for the staff, and also the least expensive for us. So it's a win in every way. P103s it's a wonderful opportunity to be a P103 in that one does not have to have a set schedule. You can decide when you want to work and when you don't want to work. There's no obligation. And it's great for that employee. It is more difficult for the unit when they're trying to schedule the rest of the staff. And there are a number of other reasons why a higher percentage of P103s is problematic for a unit. I'm not sure if that was helpful or if you need further information.
No, I mean, that's really helpful. And I guess it's just wanting to know the totality and whether you all feel that more often than not, the staffing is adequate on these critical units where we know we have vacancies.
It's definitely been a challenge, and I think it's a challenge across the country. We're certainly not unique. And I think that we've partnered very closely with Human Resources to work as hard as we can to, and as quickly as we can to try and bring in new staff. The P103s definitely help. I would certainly not turn them down. And the other resource that we have are our traveling staff. And again, not ideal, but certainly better than not having them. When you take that group, as you said, in totality, most of the time in most of the departments, I believe that our staffing is adequate, is at ratio. It's just, again, we would certainly like for it to be all 2320 staff.
Thank you. Yeah, I think at some point understanding more about ratio, which was something we discussed about 3 or 4 years ago, would be helpful from time to time just to get an overall feel for how things are going.
We'd be happy to share that information.
So actually, I think from Commissioner Green's question and perhaps and with background for Commissioner Christian, it might be good then to go over that once again to look at whether or not on a historical basis what has been our use of temps, or P103s aren't temps, but that includes temps perhaps for each of the units or something like that within a year, so that we could get a feeling that say Med-Surg has been staffed 67%, correct, with RNs, and 30% with P103s, and 10% with temps because, some of the regular staff is away or something like that. But to get some sort of an idea of what these units are in terms of where we are with staffing. How many are permanent? How many have this option and the P103s? And that'd be a snapshot in place, or perhaps it could be, in the last year, this is what we've seen since I think part of the staffing, as we saw from the census, it's not been a matter of then suddenly having an empty hospital and coming back. So you could select, the past year and that would probably be helpful in some of the key areas that we're talking about. They're probably the areas in which we have shown up. We've been following emergency critical care, medical surge, and surgery in terms of this graph that we last time were talking about trying to perhaps change and make more useful for us. And beginning to understand where the base is would be helpful, I think, for everybody at this point. So that might be perhaps a year or half year snapshot, whatever makes sense, to say, well, this is kind of the average pattern that we have. And one of the blocks, I guess, would be vacancies that that are filled with temps, or so. So I think that's one of the things that would be helpful for everybody, a new baseline to see where we are.
We'd be happy to put that together.
Yeah, I think the other thing that we were in, and I'm a little concerned, maybe I should go back to the question I had, was we're having another change in HR staffing, or you don't, I mean, this is perhaps critical in terms of recruitment if we don't have stable or permanent people, you know, within your department. I'm sure you're doing your very best, but it sounds like you're short some people.
We are, and there's constant change. So we had an operations manager join us, and unfortunately, due to personal reasons, is unable to stay, and so again, the position will be vacant. But they're already working on, you know, the new selection process for that. So hopefully, fingers crossed, we'll have another manager soon. But just overall within HR, there's just been a, you know, constant change, and so we're training staff, we're making sure that, you know, they have the resources to be able to do their jobs. But it has been a challenge.
So I was just going to ask the officers, we're fortunate to have one of the officers here to really investigate with the director what where we are with HR now again, because it's so vital for everything that we're doing, and put that onto your agenda.
Okay. And commissioners, the full commission will be receiving an HR update. I believe it's maybe September, but it's, you know, in a short time, but certainly I'll add this to the agenda for the officers meeting.
So that could certainly be part of the agenda report as to the challenges being faced again by HR, and hopefully we're not losing any sense of our urgency that we are all having. Which goes back to the graph. Still not sure, although, you know, the graph is very dramatic for all these, I think they're gray lines, and perhaps that's is value today, which unfortunately shows all these vacancies, which are higher than they've been in years. And so understanding that we're using temps to fill in, and that, you know, the hospital is maintaining, of course, the correct number of licensing, it just strikes me under med-surg, and maybe that's the dramatic effect now this year, and on the emergency services. But I do think that we've got so many little bars here that it does represent a challenge. And no, I understand HR is challenged. Maybe we can use somebody to sort of figure out. Adrian's been very good at things like this, trying to challenge how to make him, because what we want to know, right, and this could come out of after looking at your base, is it seems to me, okay, what do we have now on an ongoing basis of vacancies in each of these units, and how well are we doing filling them? That's really what the question is, and it probably doesn't need to go all the way back to 2020 at this point, but perhaps cleaning it up and it becoming a rolling year or something to try to understand. Last year in January, we were doing much better than this year in January, or something like that. But I think to get at least a year's understanding where we are. So that goes sort of back to that other question of how would you like to change the charts? I'd challenge you to look at that we're looking to see what are the vacancies. Now, we've talked about building the base. So what are the vacancies, and, and how many are we filling each month so that, we understand the shortfall. And like I said, we don't, in the past, we were keeping the numbers because we actually were very proud that we went down from 2020 all the way down for, let's just take January, for example, in med-surg. But now it's had a big surge of the 2023 bar, and I think that we're now aware and sufficiently, in background that we don't have to worry about 2020. We are really worried about 2023, right? Commissioners, does that sound right, that we try to make the chart then more useful for everybody, and yet also then see if also it can be more readable and without having to go all the way back to 2020.
Okay, we'll make an effort
Does that make some sense?
Yeah, definitely we'll focus on just prior year to this year change. And it sounds more like you want a rate and not the actual numbers, right? You want to see the vacancy rate.
Yeah, I guess that makes sense, huh? I don't know. What?
Maybe both. I mean,
Both.
numbers.
How do we do both? Can we do both?
Okay,
Yeah, let's do both for a while.
okay,
Yeah. Yeah, because I could see value for either one.
great.
Okay. And then, kind of work together with that presentation of where the base is from perhaps the previous year. So then that gives context to where we were and what's happening. So that'd be a great presentation, I think, to allow us all to understand your challenges.
Okay, we'll work with Christina's team to see if what we can bring back. Is that something that you would like to see next month, or is that, I'm not sure when that could be made available?
How about if I work with the staff to try to
Yeah.
determine timeline, because I know you might want it, but it might take them time, so I'll report back.
Yeah, I was going to say, obviously, we'd like it as soon as possible in terms of following where we are and, how challenged we are again, whether or not we have to really make big pushes again, as we did several years ago, to really pick up the challenge with you and try to support you for, moving the needle. So,
Great, thank you.
okay, thank you.
Great.
Let's go on to the next item.
Yes,
Thank
items-
you very much.
Item 7 is a medical staff report.
And we get to welcome our new chief of staff, who is going to present the chief of staff. I'm sorry that we didn't get to say goodbye to the old chief of staff,
I
Dr.
know.
Winston. So please extend to her our sincere, appreciation, and that we all wish her well in her new venture that I know you've reported on. So, and welcome to your first meeting as Chief of Staff for the Joint Conference Committee.
Thank you so much. Good afternoon, Commissioners. I was hoping to start just with a bit of an introduction to myself, since this is the first time that I'm presenting to you all in person, and so I was hoping to ask for permission for that.
Oh, please do.
My name is Gabriel Ortiz. I go by Gabe. I wanted to start in terms of my professional background, sharing a little bit about my personal background, because it influenced so much in my career. And so I was born in New York City, first generation Puerto Rican Dominican, and it was my mother who really influenced a lot of my interest in going into the medical profession. She suffered from breast cancer, and I helped navigate her through the healthcare system in New York, and seeing what a difference a physician can make in her journey as she battled breast cancer, and how challenging it could be with a physician who's not so skilled, I became very motivated, highly motivated, to pursue a career in medicine, as well as especially kind of advocate for the Latino population. And so I completed my MD PhD training at the tri-institutional program at Weill Cornell Rockefeller Memorial Sloan Kettering, where I did research in human immunology, studying how our body fights off HIV and how treatment interruptions, and more specifically, can boost the immune response against the virus and can be sometimes used as a strategy for persons to auto-vaccinate themselves against the virus. Came to San Francisco because of San Francisco General Hospital. It is really the main reason why I wanted to come out to UCSF, as stellar, excellent, and very impressive internal medicine training. But the county was really kind of the heart and soul, I felt, of the institution, and does so much for all sorts of underserved communities here in the San Francisco Bay Area, and really drew me and kind of has since stayed and built my career here. I came to do an internal medicine residency program, did an ID fellowship, did a chief resident year at the General, did more HIV research, and while I was in the lab, realized that I really loved being part of the clinical care teams at the bedside. And had some tough conversations with my mentors and kind of my kind of faculty research mentors and my infectious diseases mentors, and made the decision to transition to hospital medicine in 2012 and apply the research training, the analytical skills, and my real interest in kind of advocating for the underserved populations to clinical care and apply that to the leadership of hospital systems. And so since that time have grown my academic career in being a systems scientist of sorts, and have become trained in lean production system, practice in the lean management system, have applied systems science and kind of different techniques to improving how we deliver care at the bedside, picking and choosing our battles, so to speak, in terms of those key to quality steps in really complex hospital operations. As I grew my experience, kind of helped in some important projects like transitioning to the new hospital tower, transitioning to Epic, our new electronic health record, or not so new anymore, and lots of other improvement projects like bed turnover and delivery of discharge medications to the bedside, multidisciplinary rounds in terms of discharge planning, addressing the framework of how we care for patients who may be functionally or cognitively impaired. And through that experience, kind of drafted a position with our executive team at the hospital to create the position that I'm in now as the inaugural medical director for our med-surg care area, the hospital wards. And that's been a true pleasure. I've been in that position since 2018, leading efforts in both bedside care as well as kind of the pandemic responses across the hospital on those care units, and developing surge plans in the event that kind of we would need those. And thankfully, we kind of didn't need all of the kind of countermeasures that we kind of thought we might need. And now stand here before you as Chief of Staff, trying to fill Lisa's big shoes. It really is an honor and a privilege, I would say, to represent our medical staff. One of my key goals is just highlighting all the incredible work that is being done day in, day out by the medical staff, keeping them to kind of our best standards, and collaborating with all of you. As I've seen, kind of it looks like you all really help us do our best in terms of asking questions that help us learn more about how we can be doing even better. And so I really believe in that all improvement work stems from respect, from making things as easy as possible, because care is already complex, and then making it safe. And all of that translates into better and faster care. And so with that, I do want to thank Lisa Winston for serving in this role for the last several years. She's done an incredible job. I've learned a lot from her. As a resident who trained here at UCSF, she was a mentor both in internal medicine and infectious diseases. She's just a powerhouse. And as you'll see, as I transition into the med staff report, I'm very fortunate that she will continue to work closely with me as my associate medical director to help lead our very big department, which is med-surg. And so if you have any comments or questions about that, I can stop there. But it's a pleasure to be here to meet all of you. I'm looking forward to working together.
Well, thank you for that background, and thank you for the work that you're doing for all of us here in San Francisco. And so we look forward to your report. Commissioners, any comments before we move on to the Chief of Staff's report? Or aside from my extending the welcome of the entire committee here and certainly the Commission.
I just want to say thank you for sharing that background. It does help to understand why you're here and who you are, and it's wonderful to meet you, and looking forward to working with you. I'm glad that you're in this position.
So let's proceed. Thank you.
Thank you. I'll transition to the med staff report. We had a very, I would say, exemplary service report led by Dr. Chris Caldwell, who reported on the status of our ZSFG emergency department. Before that, it is the beginning of the academic year, so the Medical Executive Committee did review all the leadership changes that are occurring on campus. As I alluded to, really happy to say Dr. Lisa Winston has been appointed as the Associate Medical Director for Med-Surg. There is an interim chief for the Division of Hospital Medicine. Dr. Larissa Thomas is serving as our interim chief for the Division of Hospital Medicine starting July 1st. We have a transition in terms of a wonderful appointment. Dr. Ben Breyer has been appointed as the chair of the UCSF Department of Urology. And so we are actively getting a committee together to find a person that can fill his big shoes. Similarly, in the Department of Psychiatry, we have an interim chief, Dr. Mark Leary, as Dr. Lisa Fortuna has taken a position at UC Riverside and leading their department there. And finally, just in terms of our med exec or med staff committees, Dr. Bob Brody will be the new co-chair of our hospital's ethics committee. Dr. Jack Chase has relinquished or stepped down from that role. He's done a lot in terms of diversifying that committee and changing the way that committee contributes and works. Mr. Lawrence Chayal will continue as co-chair of that committee, working closely with Bob. And in terms of the service report, it was just very impressive. I think that alluding to some of the metrics that Dr. Day pointed to in terms of numbers, the emergency department is slowly seeing a return back to pre-pandemic busyness. And so Dr. Caldwell reported that the total patient volume has gone up to 68,000 in 2022, which is below pre-pandemic where they were seeing around 80,000 patients, but they are seeing an upward trend. And so they're expecting that as kind of society is moving back and opening up back to normal operations and traumas and other things pick up, that the emergency department volumes will also pick up in hand. He reported on their various contributions in terms of both academically. They have a very robust faculty, 52 members. Half of those serve full-time. They serve various roles, leadership roles across our hospital and the Department of Public Health. Their trainee program and how they contribute to both the residency. They have 16 residents per year. 30% of their graduates remain in academics, which just shows in terms of the culture of what they're teaching and espousing in terms of delivering to the body of knowledge. They have various fellowships that they contribute to, long list: global health, med ed, emergency med services, toxicology, ultrasound, and research fellowships, which was very impressive. There are over 120 medical students who rotate through the emergency department per year, which serves a robust pipeline for their residency program. They inspire lots of young minds to pursue a career in emergency medicine. And as touched on at the last Joint Commission meeting, they also have leaders of the EMS system embedded within their faculty group, which serves them really well as a trauma program, I think, and as an emergency department in general. I think, you know, they're extremely strong partners, I would say, in terms of the announcement of how our trauma program passed with 0 deficiencies. The emergency department is a very strong partner in that program. Turning towards performance improvement, they have a very robust set of initiatives. They're working on addressing staffing, ED diversion, and workplace violence, along with continuing work in patient satisfaction in the waiting room, time to EKG, being an age-friendly ED, working on patient monitoring during transport, and opioid treatments in the emergency department. They have robust work on equity in their department, and they've been working, because of the complexity of the department, on how to communicate effectively across their staff group, and have piloted this eDrive tool, which they kind of use as a centralized repository of information to be able to keep a cohesive unit in terms of being knowledgeable of all of their policies, procedures, and tips and tricks in terms of delivering great care. In terms of their focus on diversion, they were able to decrease their diversion rates down to 35 to 40% in the last 2 months, and their ultimate goal is to get that down to 10%, as kind of, you may have seen some of the numbers in Dr. Day's presentation. And that's led to some challenges in the waiting room. So kind of in response to ED diversion going down, the numbers that leave the waiting room left without being seen or left without being triaged has gone up. And so they've turned their attention to how to take efficient care of patients from the very beginning, and they've started that with a value stream map to learn the processes that are occurring up before the patients make it to the back of the emergency department, to try to enhance those steps and kind of enhance the patient experience up in the front of the emergency department. And then in terms of some other notable things that kind of were brought up, I would say that the highlight was really the faculty accomplishments. They have Dr. Malini Singh, who received the ZSFG Exceptional Physician Award for all of her contributions, and Dr. Renee Shah, who has an impressive 7th NIH R01 grant on top of kind of being a faculty member in the emergency department, and lots of peer-reviewed publications. So I would say kind of a very inspirational report, and I think the strengths that Dr. Caldwell highlighted were their staff, their faculty, and kind of just being committed to the community that we serve. And challenges just including the different staffing sources, ED diversion, and kind of some challenges in terms of getting that number all the way down. He didn't mention it here, but the kind of the census being, the hospital being so full doesn't help in terms of getting patients through the emergency department who are admitted. And then the goals are to reduce length of stay, reduce left without being seen, improve the patient experience, continue enhancing the culture of care, streamlining the workflow algorithms, and then kind of this idea of focusing on the right patient, delivering the right service at the right time, at the right place. As top priorities. And so he was lauded for kind of delivering a really, as I started with, an exemplary report, kind of touching on just the breadth of activities that are going on in a very busy department, the emergency department. In terms of their rules and regulations, there were some minor changes. They added an assistant medical director leadership role to their rules and regs in order to assist in leading this very complex department. Minor changes to how attending place their request for shifts, their scheduled shifts. Some minor rules changes for requests for changes for residents and students. Some updating in terms of their appropriate dress policies, and then minor verbiage to changes in terms of how they transfer trauma patients from outside centers. and appreciate the questions submitted in terms of this report in advance. I can try to address those and then open up to make sure I've addressed those appropriately. I think the first question had to do with the documentation and coding, and noticing astutely that for codes 99281 through 99285 that the reimbursement rates have decreased. The emergency department has a pretty robust back-end system of checks for their documentation. So they use a third-party coding company that specializes in Profi coding. They then have an administrative staff member dedicated to then reviewing that in-house. And then finally it goes to a faculty member who is the point person for who serves as their documentation expert. He provides chart review, faculty education, and input to kind of enhance the build to try to get them to chart easily the right things to be able to represent the care that they're delivering. However, it kind of didn't answer necessarily why the numbers have gone down, and so I can we can continue to monitor that. I think that they do have, though, these systems of checks, and I think they're working on continuous improvement in terms of the charting workflows and the documentation to try to continue to enhance that. A second question had to do in terms of transfers to the urgent care center. They don't have any agreed upon kind of workflows with the urgent care center. They have, they asked them to follow their they do have agreed upon workflow with the urgent care center. They asked them to follow those transfer rules as best as possible. The ED does not refuse any patients, and so if a patient gets transferred from an urgent care center from the urgent care center, they never refuse, and they care for patients whether they come from the urgent care center or from any other part of the campus. They'll kind of take care of those patients. And the last question in terms of the interpreter services and kind of how the internal policies. You all noted that kind of there's language there that says whenever possible they use interpreter services. I had a good conversation with Chris, and it basically kind of this takes into account those emergent situations where the patient may be unconscious, may have no family members, and where emergent care needs to be delivered. And so I think the aspiration is to always use an interpreter. However, acknowledging that there are certain emergency situations where the patient may not be able to communicate, yet resuscitation may be needed. In those situations, they soften the language to whenever possible, because there are those emergent situations where the patient is just unable to engage with an interpreter. So that concludes the ED service report and their rules and regs changes.
Thank you. Is there any public comment?
Folks on the line, we are on item 7. If you'd like to make comment, please press *3. I don't see any hands.
All right, thank you. Commissioners, questions? Questions, yes. Commissioner Green.
Yes, I just wonder, based on what you said, because I know we've been cited for it's universal for all hospitals. They've really clamped down, the Joint Commission, on the use of interpreters that are not certified. And I think we've even had one episode last year in the ED where there was a communication issue. So I'm wondering if, just for clarity, this should say something that reflects what you just said, which is that rather than using them wherever possible, maybe you append to say that whenever, unless the patient or family are unavailable or can't communicate verbally. Because I think they've certainly been clamping down, the Joint Commission, on this whole issue of interpreter use.
I think that's a fair comment. I'll bring that back to the department. Absolutely. But
it's a wonderful report, and the work is incredible, just incredible.
Any other comments? So thank you for the report and a extensive report on the emergency services. I'm wondering, because Dr. Brown brought up also this issue of being the only trauma center. And I actually I was first going to comment that it sounds like the residency program is doing very well. And I remember in 2008 when it was started, and it was predicted that it would help bring in a number of people who would be really not only trained, but would be part of our system. So that's really nice to be seeing that that's happening. Going back to Dr. Brown and the question of the single trauma, Dr. Brown's presentation at our last full commission spoke about that as being a challenge. And many years ago, the decision had been made amongst, I guess, all the hospitals and the city that all trauma would go to San Francisco General. So it sounds like there are some issues related, and Dr. Brown, of course, talked about backup, and obviously if General was not available, then this would become a very real problem. But do you have any sense from the emergency department's report how they're viewing this? I mean, we heard Dr. Brown's anxiety about not having any backup as our EMS medical director, right? And here it indicates that it's a challenge here, and I'm also wondering if then you're all looking at this as a sort of an area that's got to have more backup, or that you still want to remain the only trauma center. I mean, I could read it as saying there are other people wanting to do trauma, or we're looking at the need that there be more facilities available. I mean, either way. So I'm not sure what the sense was in the report.
I think that it's a great point, and I think that the emergency department, along with our service chief for trauma, Dr. Joseph Cuscieri, kind of have ongoing conversations around this type of disaster planning and how to be ready for worst case scenarios. And so I think that there have been discussions around how to kind of deepen the bench, what sites could be used as even for, helicopter transport and other things around the city, and how to partner with other sites across the city in terms of delivering trauma care for kind of surges where kind of the demand for treatment might exceed what our hospital is able to provide. I'm not sure kind of the status of those conversations, but I know those conversations are ongoing, and a lot of thought has gone into how to be prepared in events that kind of the demand would surge past what the general is able to provide.
Sure. Okay. No, I was just curious about how it sounds like the department's cooperating with the work Dr. Brown's also trying to do with the EMS people.
Yeah, they've thought a lot. They've thought very deeply about this, and I think in partnership with our trauma leadership as well.
Good. In terms of the rules and regs, I don't know if you saw my comment in which there seems to be either some typos or some questions, which specifically seem to say that the section on the operational issues seems that there needed to be some labeling that was more adequate, because it's on page 19. It begins with D and E, and then goes on to C, and then there actually are two C's, and not sure which C is being, proposed. And then D again, F and G.
Right.
So,
Yes, I will kind of go back to this document and try to clean up that it looks like that might have been a word gone awry in terms of the outlining.
So I'm not sure, because under sick calls and missed shifts, you have two items, but they actually say different things. So which one are you asking for approval for?
I would need to go back to Chris and kind of determine which of those C's. It looks like they intended to maybe remove one of those C-sections, and I'm not, I'm not sure which one.
Okay, so since I think we're not quite sure, and there is also a question about the wording for the translators, I'm wondering if it would be appropriate for you to come back with this, with a clarification of what the operational issue section is supposed to read like, and perhaps I'm not sure that you have the time, depending on when this needs to be passed, to also look at the translation question as to how that could be reworded.
Yeah, that sounds fair. I can kind of work with Chris and bring this back to our next meeting here.
Okay, is that fair for everybody? Okay, good, thank you. I think that is the end of the medical staff report at this point. You have a lot more work to go on
Yes.
in our closed session, so
Thank you.
we will go through the rest of the agenda here first before the closed session.
Congratulations on getting through your first report. Item 8 is other business.
Commissioners, any other business that you want to bring up at this point? Seeing none,
If I may just ask for the folks on the line, if you'd like to make comment on other business, item 8, please press star 3. All right, no, none of that. Item 9 is public comment, general public comment. If you'd like to make a comment about something that's not listed on the agenda and has been discussed already, please press star 3. No hands for that. And now, commissioners, we're on item 10, a consideration for a closed session.
so a motion for a closed session is in order.
So moved?
And a
Second.
second? All those in favor, please say, we have to have public comment.
Yes, I forgot about that too. Folks online, if you'd like to make comment on the consideration for a closed session, please do so now by pressing star 3. No, no hands, commissioners.
Okay, thank you. All in favor, please say aye.
Aye.
All those opposed, therefore, we will go into closed session.
All right, folks on the line, we will be back, but you will not see us or hear us while we're in closed session. And then everyone else, please give me about 30 seconds to take us into closed session. Into open session. Commissioners, please consider a motion to disclose or not disclose. Discussions held in closed session.
So a motion?
I move that we not disclose the contents of the closed session.
Second.
All those in favor of not disclosing the contents of the closed session, please say aye.
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 And now we're prepared for a motion for adjournment.
So moved.
And
Second.
all those in favor of adjournment, please say aye.
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 We are adjourned. Thank you very